Hi everyone, welcome to the sixth edition of our spotter case discussion. Hopefully I'm audible. We're on time, so we'll start the case discussion. So Ayush says, has it started? So no, we are just starting discussion. So before we start our case discussion today, uh, there was a small error in one of our previous cases, and I'd like to highlight that. Thanks to Dr. Avikalp Kumar who pointed out this. So during the case presentation, I said that this was a T1 weighted image. This is actually a flare image. So thank you for pointing out the error. Uh, at times it's difficult to, like errors do happen, especially when we are doing a live stream. We tend to ignore smaller details, but I'll try to be careful henceforth. And if you find any errors in any of our presentations, please type in the comment section or let me know, and I will try to amend those. In our previous slides, Dr. Venkatesh had mentioned about the findings in hyperosmolar coma. I had said that we get parietal hyperintensity when in fact it is hypointensity, as he rightly pointed out. Okay, so moving on to today's case. So this is our first case today. I'll just change the setting because the image is looking a bit stretched. I think it's better now. Okay. So this is the first case for today. So today we'll discuss mostly MSK cases. MSK cases are difficult on just single image. So we'll try to discuss as much as possible. Most of the times the pathophysiology is quite extensive and not related to that single image. We'll try to do as much justice as possible, but remember that MSK, you have to look at all sequences, all images, and there is always more to the imaging findings with MSK. Okay. Okay. Good differentials. So what we see here are so these are fat saturated water sensitive images. It's difficult to point out PD versus T2 fat sat, so I usually avoid the term. Water sensitive sequence I find it easier that way. So what we see, so this is a coronal section, and this is a sagittal section. So there is some tendinosis here, although we need T2 to confirm that. We don't have a T2 image to 100% say whether this is tendinosis or tear. The finding here is in this region. So let's see if some people have mentioned calcific tendonitis. I don't see any areas of blooming, although this is not a typical sequence. So these are the areas where we are looking for the findings. A couple of correct answers, but I'll just wait for everyone to settle in. And supraspinatus tendinosis is a differential here, but we don't see T2, so this is not the finding that I am interested in. These are the areas that I want you to look at. So this area and this area. Okay, so what we see here is that there is thickening of the inferior the axillary recess of the shoulder joint, and there is hyperintense soft tissue in the in the rotator interval. So how do we know what the rotator interval is? This is the humerus. In a sections if you move ahead or behind, you'll get the coracoid process here. This would be the coracoid ligament somewhere, and then the fat structure beneath the coracohumeral ligament is the rotator interval. So what we, as I said previously, there is thickening of the axillary recess of the glenohumeral joint with the hyperintensity. The same is seen on the sagittal images, and apart from that, there is this hyperintense soft tissue in the rotator interval. So this is frozen shoulder or adhesive capsulitis. In today's session, what I've done is the titles of the slides are your take-home points. So even if you don't look at the rest of the slide, make sure that you understand the important clinical take-home points. So frozen shoulder is a clinical diagnosis. Imaging, the role of imaging is only to rule out other causes of the symptoms. So although with MSK you must have observed that many a times our clinical diagnosis doesn't match with the patient's symptoms or the impression of the orthopedician. So you have to remember that most MSK pathologies, the clinical presentation is important, and this is particularly true in cases of spine. You may have a disc which is causing a large, severe compression, but the patient might be completely asymptomatic. So frozen shoulder is one of those diagnoses where it's a clinical diagnosis, and imaging is, the role of imaging is just to rule out other causes. So most commonly we see it in 40 to 60-year-old females, and the diagnostic criteria is capsular thickening. Highest sensitivity is when we use the thickness as more than 9 millimeter, and T2 hyperintensity in the axillary recess portion of the glenohumeral joint capsule. Abnormal soft tissue in the rotator interval, as we saw, and thickening of the coracohumeral ligament more than 4 millimeter. Our sections didn't have the coracohumeral ligament, but you look at the coracohumeral ligament in the sagittal sections, and this is this is the area where it will be. It will be a thin structure usually, but when it's more than 4 millimeter, we call it adhesive capsulitis. Moving on to the next case. So again, this is a water-sensitive coronal sequence. The first image. The second image is a early phase of a contrast study, and this is a delayed phase. So MSK is difficult, especially the joints. What we'll try to do cover today is a spectrum of MSK abnormalities instead of just sticking to joints. If you want to learn about joints, the easiest way is to learn the anatomy first, go over multiple sequences. There are very good anatomy modules. We have listed all of them on our website. If you head over to radiogyan.com, and there's a menu at the top, and anatomy section is highlighted there. So we have all anatomy modules for CT, abdomen, MR, abdomen, and all MSK. So I've just collected all of them at one place for ease. So go over the anatomy in multiple planes, and then pathology becomes easy. So moving on to this case, let's see. Okay, we've got a couple of good answers. So what we see here is a septated, kind of ill-defined lesion extending, almost involving the entire left thigh. It's hyper-intense on fat-saturated images, and you see these small septa. We don't see any obvious phlebolyths, although this is not a very good sequence to look for them. The ideal sequence would be so apart from a radiograph, what sequence on MR would you look for phlebolyths on? What sequence is preferred? The same sequence you'll use to look for loose bodies on say a knee MRI in an osteoarthritic patient. Yeah, so yeah, Dr. Ala has rightly pointed out a gradient echo. Yeah, everybody's got it right. So a gradient echo sequence will cause blooming of these calcific densities or phlebolyths, and that is the ideal sequence. So we describe the appearance on this fat saturated sequence. On the early arterial sequence, we do see a few bleps of contrast, but however we don't see, maybe there is minimal contrast here, but we don't see any arteriovenous shunting. So most of these are arteries, we don't see any veins yet. However, in the delayed phase, you see that this lesion is started slowly picking up contrast. So you see here it started picking up contrast. So this is a case of slow flow venous malformation. An important caveat here is that we often use these terms very loosely. So there is a new classification. It's quite extensive, but these are the important points from that. This is a very nice radiographics article. So this is, for those who are not aware, this is what is known as a QR code. If you point your phone's camera at this, it'll show you a hyperlink, and then you can directly visit the article. It's easier than referencing the article itself, because then very few people will actually visit it. So later you can just point your camera to this, and this will directly lead you to the URL. Most of the phones have this built in. Alternatively, they have an app called Scanner, or you can use Google Lens to do this. So you can read this article. I'll go over the important terms for vascular lesions. So the first lesion is hemangioma, and most commonly it is it's the most commonly abused term. Whenever we see a vascular malformation, the first thing that we say is hemangioma. So not all vascular lesions are hemangiomas. So there are vascular tumors and there are vascular malformations. So hemangiomas are vascular tumors. These are usually seen in children, and then they involute on their own. Rarely propranolol, which is a beta blocker, can be used to decrease the vasoconstrict the vessels and help with the involution process when it is large. On imaging, there are two phases, the proliferating and involuting phase. What we see is a well-defined mass which is low signal on T1, as most pathologies, and we'll see flow voids on spin echo sequences, that is our routine T2 weighted images, and there is no perilesional edema, and the enhancement is early enhancement. Now moving on to malformation. So this should be low flow rather than slow flow. Apologies for that. So that low flow malformation, so they can be venous or lymphatic. Capillary low flow malformations are typically skin level lesion, and we don't see them on imaging, so we can ignore that portion from an imaging perspective. Venous malformations are similar to our case. If I had to give one diagnosis here, I would put a venous malformation. The distinguishing feature in from venous and lymphatic malformation is phlebolytics. You don't see any phlebolytics on in lymphatic malformation. And the other characteristic is that this will show diffuse enhancement on delayed phases, and because lymphatics usually don't have a lot of, it'll take some time for the contrast to get into the lymph system, so they don't show homogeneous enhancement. They show just slight diffuse enhancement. And high flow vascular malformations are AVMs. So always whenever you are doing a Doppler, make sure that you put spectral waveform to see what kind of waveforms are we getting in a vascular malformation. So I have seen say sonologists and radiologists, they'll do the Doppler, but they'll not put the spectral flow. So if you don't have the spectral flow, it is not possible to tell whether it's an arterial flow or a venous flow. So make sure that you put your spectral waveform on these as well. An important management caveat here is that these low flow vascular malformation are amenable to percutaneous sclerotherapy, which is often done by intervention radiologists. So that was vascular malformations and vascular lesions in brief. Please go through this article and the International Classification of Vascular Tumors. I forgot the abbreviation, but you can just Google and go over the important points. It's quite extensive. You do not need to know the entire classification, but you can go over the important points. And again, main point is that not every vascular lesion is a hemangioma. Okay, so moving on to the next case, we have an AP radiograph of the knee and the corresponding non-fat sat coronal image. Okay. Okay, I'll give some time and then maybe I'll point out the abnormality. Okay, most of you are getting it right. I would stick to what we see. Dr. Vivek has mentioned about an ACL injury. I'll go over that as well. Okay, so so for those who finding it difficult to get the finding, this is the finding in this case. This is medial, this is lateral, and this is the abnormality that I want you to pick up. Okay, so a couple of so in the exams, or even like in the exams in clinical practice, obviously you'll get the entire set of images to comment upon, but overcalling can get you in trouble. So I would in this case I would only talk about a Segond fracture. You see this avulsion fracture along the lateral aspect of the tibia. That's a Segond fracture. I do not see a AC, although there is something happening here, but I don't see an ACL injury and I don't see a meniscal injury, especially on these sequences or these images. So I would not call it like an ACL injury or MCL. So make sure that you don't overcall on, especially in spot radiology cases. So what is a Segond fracture? And this is the take-home point, that always look for an ACL injury. So avulsion fracture of the lateral tibial condyle. The origin of this is a bit debated. Some people call it it's an avulsion of the lateral collateral ligament. Some people say that it's the anterolateral ligament that is avulsed. In fact, the existence of an anterolateral knee ligament is debated, and it's one of the most talked about topic in knee MSK radiology. It doesn't matter because the fracture per se is not very important. The important thing to remember is that this is associated with ACL injuries. There are multiple studies quoting different values, but at least 75% of the cases, like 75 is the lower number that I could quote, and meniscal tears. So avulsion fracture of the lateral tibial condyle and associated with ACL injuries. In skeletal immature patients, this may the ratio like the incidence of ACL injuries is slightly lower. So that's just an additional caveat. So Ayush had asked about the previous case, whether we can call it Klippel-Trenaunay-Weber syndrome, but I think it's a triad and usually a clinical syndrome. The additional imaging finding which we may see is localized gigantism. So for example, if you go to the case, both limbs were like okay, like I don't see gigantism that much, so I would avoid that diagnosis. Especially I don't see the typical cases, especially if it's a spotter, you'll see a huge limb with a vascular malformation, which is typically a venolymphatic malformation. But agree, that is a good differential for so yeah, again Vivek is talking about the medial meniscus. It may be, but again on a single image I would avoid. It can be, but on a single, like I see what you're trying to say here about the medial meniscus, but it's very difficult on a single image. You can still comment upon it, but if you have like a one classic diagnosis, I would avoid a second one, especially in this case. But I agree that here it looks a little bit, but not too much, not very convincing. But yeah, so you're right that it's associated with ACL injury and meniscal injuries. Okay, moving on to this case. This is a tough case. Not a spotter. uh, I don't expect a lot of you to get it right. If you get it, that's very good, but I just had an interesting case, so I thought I'll share. But even if you don't get this one, it's perfectly fine. Even I would not get it if I was attempting a spot set. Very good, Ashwini. You've pointed out to the abnormality. So that's the first step, that you'll find the abnormality. Many a times in the exams, even if you're not able to get the diagnosis, what you can do is at least try to write the abnormalities. You may not get the full marks, but if the examiner is satisfied with your answer, he may give you at least partial, like some marks. And sometimes what happens is that when we write down the abnormality, you may come to the diagnosis as you see that more. So good that you pointed out the abnormality. A few of you have got it right. Marwa, you also pointed it out. Stuti, is this a pediatric patient or an adult patient? We discussed Köhler's disease, a very good case in our previous lecture. I'll leave a card to that in the corner so that you guys can check it out. I'll leave a card right here later so that for those who are watching it and haven't seen the previous lecture can check it out. Okay, so this is a adult patient. So Köhler's disease would typically be seen in a pediatric patient, but you have rightly pointed out the abnormality. So this navicular bone, if you see, is slightly more sclerotic as compared to rest of the bones. And on the CT, you see like this portion of the clavicular bone, the lateral aspect is slightly smaller than the medial aspect and is more sclerotic. Sorry, the medial aspect is more sclerotic than the lateral. The same thing I'm trying to show here. So you see this areas of sclerosis. So this is what is known as a Mueller Weiss syndrome. So this is an adult form of Köhler's disease. So adult onset osteonecrosis of the navicular bone. Patients present with chronic midfoot and hindfoot pain. So it's not a abnormality. In MSK and in many intricate joints, what happens, like especially the wrist and the ankle, one abnormality can lead to a cascade of abnormalities. For example, in a wrist, if you get a scaphoid fracture, it will lead to a sequelae of abnormality. So you have to look for the rest of the abnormalities as well. So this article describes this progression of Mueller Weiss syndrome. It starts initially with just mild sclerosis and reduction, and then ultimately there is fragmentation of the lateral aspect of the navicular with progressive compression, and then in the final stage there is a pseudoarthrosis between the talus and the cuneiform, and wherever you get this pseudoarthrosis, they can cause a lot of pain. So you can refer to this article. This describes the pathology and this sequence of events very nicely. Moving on to the next case. So this is a axial non-fat saturated T1 image at the level of the elbow joint. Okay, does anybody see any abnormality? Again, it's a difficult case, especially in a single image. Okay, I'll point to the abnormality or the anomaly, I should say. So let's get oriented. This is the lateral aspect, this is the medial aspect, And this is the abnormality or anomaly in this case. High signal in accessory lateral muscle. This is a T1 weighted sequence, so this is probably artifactual, but good that you pointed out. Usually we don't like T1 is not very good at commenting on muscle signal. This is probably related to artifact, but this is the anomaly that I would want everybody to observe. This is one muscle, this is another muscle. So what this is a Anconeus epitrochlearis, which is a normal variant. Normally the Anconeus muscle, so this is a normal study and this is our case. Okay. So this is the normal Anconeus muscle on the lateral aspect of the elbow. This is an accessory Anconeus muscle or Anconeus epitrochlearis. Usually it does not cause any issues, but sometimes it can cause neuritis. So which nerve is present on the medial aspect of the elbow? In fact, it's seen in this image. So what neuritis is associated with Anconeus epitrochlearis? Perfect. So the ulnar nerve, I'll point it here. This is the ulnar nerve here. This is a normal flexor glute muscle. This is the ulnar nerve here. If this muscle hypertrophies, it can compress the ulnar nerve and cause ulnar neuritis. And before we move on to the next case, I just want to confirm the laterality. So this starts at the lateral aspect of the navicular. I'm not sure what I said in my image. Yeah, so this is an inverted CT image, so that's causing the confusion, at least for me. So it starts on the lateral aspect. If I said medial before, my apologies for that. So just to confirm that it starts on the lateral aspect and moves on to the medial aspect. Apologies if I said medial earlier. Okay, so this is our next case. It's a fairly typical case. I've included here because it comes in the spectrum of MSK neuro abnormalities, and just as a kind of a icebreaker and breaking the MSK monotony. Perfect. So most of you have got it right. What we see here are these hyperintense foci involving the basal ganglia and multiple elongated. So this remember this appearance, this elongated kind of appearance with a central hypoechoic area, that is very classic for neurofibromatosis, and these are known as facies, that is foci of abnormal signal intensities. They are characteristics of neurofibromatosis. So you see multiple neurofibromas here, you see a neurofibroma here as well, probably there's one here as well. So this is what is known as a whole body MRI, and you see multiple of these here as well. When they are bunched up together, say 4-5 nerves together, we call it plexiform neurofibroma. And so neurofibroma, there are multiple types, 1, 2, there is a type 3, there is a type 5. These are all old terms. You can refer to this article. I have tried to cover the most important findings in cases of neurofibromatosis in this article, and mnemonics to remember each of them. How do you distinguish a neurofibroma and schwannoma, and how do you differentiate benign versus malignant nerve sheath tumors? Important like a nice mnemonic which I learned while I was doing my postgraduate entrance exam is that neurofibromatosis has 17 letters. So that's how I remember which chromosome is the gene for neurofibromatosis located. So neurofibromatosis 1 is located on chromosome number 17, and neurofibromatosis 2 is, because it has 2, so it is 22. Not relevant for radiology, but just a neat way of remembering the chromosomes for these go over this article because neurofibromatosis is commonly asked in the exam, and there are multiple skeletal, abdominal, and so findings, and each of them is a bit different. So I have covered all of them in that article. Moving on to the next case. So this is a lateral view of the tibia, and I'll discuss the findings in a while. Let's see if So we have around 40 people today, which is very good. There are a lot of conferences going on right now. So considering that, having around 40 people is a good number. Okay, perfect. Try to be more specific. So Aswini mentions osteomyelitis. That's what I assume he means by OM, but there's a more specific diagnosis here. Perfect. So what we see here is that the first finding that catches our eye is this periosteal thickening. So if you look at the posterior periosteum, it's probably normal, but especially if you look here, the periosteum here at the cortex is very thin. So I mean the cortex, not the periosteum. So the cortex is very thin, but if you come on to the diaphysis here, you see that the cortex is abnormally thickened, and there is a area of altered marrow signal intensity, and there is this tract draining up to the skin. So as all of you have pointed out, there are in fact maybe couple of tracts. This one is not that seen well, but at least these two are kind of convincing. So this is chronic osteomyelitis with multiple sinus tracts. So chronic osteomyelitis, there's often a confusion in these terms. So as you know, as the name suggests, it's chronic infection of the bone. So usually it's a low-grade infection, or the body mounts some response, or there is partial resistance to antibiotics. So some of that pathology is involved. That is why acute osteomyelitis progresses to chronic. So osteomyelitis starts with periostitis. Because of this, there is the inflammatory cytokines give rise to a response which causes increased pressure in the subperiosteal space, which causes infarction, and that leads to dead bone, which is known as sequestrum. So sequestrum is dead bone. There are multiple types of sequestrum: button sequestrum, ring sequestrum. So you can read about them. Some pathologies are associated with each of these subtypes of sequestrum. Typically, where do we see button sequestrum? So there are multiple pathologies in which we can see a button sequestrum. The typical description is that for a eosinophilic granuloma. It's not specific, but you see it in multiple pathologies. So what happens after that is that there is periosteal new bone formation, which is known as involucrum. Because there is a lot of inflammation, reaction, pus forming in the bone, and it has to come out, there are multiple defects in the involucrum. They are known as cloaca. And these cloaca then reach up to the skin, and then they are known as a sinus. So I hope this pathology is clear, and for those who already know this, it's a kind of a revision for them. Coming out to this, so a long-term sinus can give rise to squamous cell carcinoma. And what is that ulcer known as? So what is a ulcer which is due to chronic sinuses known as? Perfect. So most of you have got it right. So it is a Marjolin's ulcer. Hopefully I've got the spelling right. Okay, yeah. So it's known as a Marjolin's ulcer. Okay, moving on to the next case. So this is a AP radiograph of the pelvis, and as you see, it's in a pediatric or adolescent patient, and this is a coronal water sensitive sequence for the same. I'll wait for a few answers and then I'll point to the abnormality so that it's very difficult, especially in spot images. Very good. So it's a very subtle finding, and I see that a few of you have picked it up, which is very good. For those who have not picked up the abnormality, this is the abnormality here. If you compare this versus this, so you see this tiny bone fragment here. The same thing is seen here. We don't see the fragment really well here, but there is this fluid separating the anterior inferior iliac spine and this tendon. Here it's normal. This is the normal attachment to the anterior inferior iliac spine. So let's see if somebody is saying Perthes. The femoral head look okay to me. I would not suspect a Perthes here. So what muscle is attached to the anterior inferior iliac spine? I see a couple of answers. I'll wait for everyone to try it. So what muscle is attached to this abnormality? Very good. So yeah, so the correct answer is rectus femoris, and what this is an avulsion fracture of the right rectus femoris from the anterior inferior iliac spine. In fact, we had this case on our website, and it was Dr. Allah who pointed out a mistake in the diagnosis that I had put up. So I thank her for doing that. I had mistakenly mentioned that it is an anterior superior, I think, but she corrected it to anterior inferior iliac spine. So this is a avulsion fracture of the anterior inferior iliac spine. The rectus femoris tendon attaches there. Couple of important points regarding avulsion fractures. These are commonly seen in adolescent patients, and they are more common in athletes. So if you see a degenerative, say an old patient with the hip MRI, the chances of it being an avulsion fracture are slightly low. So these are high impact injuries, high velocity injuries, not impact, and commonly seen in young male athletes. An interesting thing which I read while preparing was that they are commonly at these secondary ossification centers, which are also known as apophyses, and because these are just forming yet, they have not completely formed yet, they are prone to avulsions. So that is why there are two things that are important here, that avulsion fractures occur at these secondary ossification centers, and they occur around puberty when these are not really well developed. So that's very interesting. That's an interesting thing that I learned. And the most commonly is ischial tuberosity, where the attachment of the hamstrings is present, and the less common is anterior inferior and anterior superior iliac spine, as we saw in our case. This is a nice image from Learning Radiology, where it talks about all avulsion fractures. So let's start from the iliac crest. The abdominal muscles attach here, so you can get a fracture there. The sartorius, as somebody mentioned, attaches at the anterior superior iliac spine. The rectus femoris attaches at the anterior inferior iliac spine, as it was in our case. The iliopsoas will start here and get attached here. The iliopsoas muscle attaches at the lesser trochanter. The adductor group of muscles attaches at the pubic symphysis, and the ischial tuberosity has the hamstrings, that's the biceps, semimembranosus and semitendinosus, and finally the greater trochanter has the gluteal muscles attaching to it. So hopefully this is kind of a good revision for you guys. Later you can come back and revise this slide. It's a nice slide which talks about all avulsion fractures and all muscle attachments to the pelvic bones. So this is an interesting case, and I'm sure that quite a few of you may not get it. and I'll talk about the reason why you may not get it. So I'll wait for you. So this is a water sensitive coronal sequence, and this is a non-fat saturated sequence on the left. So as we move on to our last few cases, again, as every time, I would request everyone to give their feedback. So far we are getting positive feedback, we're getting few suggestions, and I'm trying to incorporate all of them wherever possible, and that's how we'll improve. The reason I ask this every time is that it's not important how much I know, how much are you taking back from the lecture. That is more important in any lecture. I might know hundreds of things, I may not know a lot of them, but if I'm not able to convey whatever we are talking about, then it's a waste of say 30 or 45 minutes that we sit together during these classes. So make sure that if you like the discussion and the format, you give us a thumbs up, and even if you don't like anything, give us a thumbs down, and let us know how can we improve, and what can we change in the format, or what new things when we can introduce. We are trying to get in polls so that there is more interaction, but it's difficult to set up everything, especially like if you want to go to a different platform, that's not ideal. So all suggestions are welcome, and yeah, you can subscribe to the channel for all future updates, and if you like the content, make sure that you share it with your colleagues. The best way to remember anything is to teach them, so you can use these slides and teach them. And for more cases, you have our website where we have around 600 cases. Okay, so let's see what we've got so far. Okay, so as I expected, most of you have called it SONK or SPONK, but Dr. Janice has rightly pointed out, Dr. Janice and Dr. Marwa, you've rightly pointed out the diagnosis. So what we see here is that there is this subtle condyle irregularity, and there is a lot of edema in the medial condyle. So you see the fibula here. So this is the lateral aspect, this is the medial aspect. So I'm doing this exercise because even for me it's very difficult at times to get oriented first. So what is lateral, what is medial? So I try to get the orientation first, because there are a lot of pathologies which affect the lateral aspect of the knee. There are some which affect the medial. So this is one of those pathologies. So this is lateral, this is medial. What we see here is extensive edema on the medial femoral condyle, and there is a subtle hypointensity on non-fat and fat saturated images. So this is a subchondral insufficiency fracture of the knee. So SONK, as it used to be known as spontaneous, or SONK or SPONK, spontaneous osteonecrosis of the knee. So the Society of Skeletal Radiology has come out and has said that that's a old term and it's a misnomer, and we should stop using that term, because it's not osteonecrosis, it's a subchondral fracture. So that's the preferred term, although some examiners may want that term, but the correct answer is subchondral insufficiency fracture of the knee. So also known as Albach disease, it's commonly unilateral, and the medial femoral condyle is most commonly associated. And another important caveat is that it's associated with meniscal tear, so always look for meniscal tears in these cases. So remember that it's no longer known as SPONK or SONK. The preferred term is subchondral insufficiency fracture of the knee. Hope that from henceforth, hemangioma and SONK, these are the two takebacks that you're going to avoid using in your reports. So hemangioma, be careful. It's not that we don't see hemangioma, but make sure that you don't call all vascular malformations as hemangiomas. And SONK is something you should completely avoid. So yeah, this is today's last case. It's so the history here is that this was a kid, as you can see from the radiograph. This is a pediatric radiograph. This was a young child who was operated for a bone tumor 1 year ago. This is today's last case. So what bone tumor did this person have, or what kind of bone tumor may not be specific, although there is one particular tumor in this age group, but there's a group of tumors which can give rise to this appearance in children. Perfect. So as a few of you have rightly pointed out, Ayush, Stuti, Dr. Sapna, Manish, Jyoti, perfect. So what we see here is that this is a chest radiograph. The lung markings are not reaching towards the peripheral portion, and there is this subtle line. It's very difficult, especially over projected images, a single image, but I hope you can appreciate this subtle line. So there is pneumothorax, which is better demonstrated in the CT, and there are these cavitatory metastasis. So what happens is that in osteosarcoma, the metastases are peripheral and they are cavitatory, so these can burst open into the pleura, and that can give rise to pneumothorax. So this patient had an osteosarcoma, and these were cavitatory mets from osteosarcoma causing pneumothorax. Oops, sorry for that slide. Okay, so we'll go over the cases that we discussed. We discussed adhesive capsulitis, which is a clinical diagnosis. We discussed the imaging findings. We discussed a low flow vascular malformation, Segond fracture, and why we have to look for the ACL. We discussed Mueller Weiss syndrome, which is a rare syndrome which may not be a spotter. We discussed Anconeus epitrochlearis and what pathology that it can cause. It's also known as cubital-tunnel syndrome, similar to the carpal tunnel syndrome because there's compression, so it can cause cubital-tunnel syndrome. We discussed neurofibromatosis. Please go and check out our article where we discuss this in detail. We discuss the pathophysiology of chronic osteomyelitis. We discuss various avulsion fractures of the pelvis. We discussed what is a SIFK and why we should not be calling it SPONK, and lastly cavitatory mets and pneumothorax in a patient with osteogenic sarcoma. If you guys have any doubts about any of the cases, we can talk about them, and hopefully you guys learned a couple of new things in today's lecture. Does anybody have any questions? You can take a few questions. Welcome Ayush and Janice, and thank you all for coming for today's lecture. And the more people you see on the live session, the more the discussion is, it's better for me, like more doubts are solved, and even there's a lot of learning for me. So thank you guys for coming in, and I'll see you guys in the next lecture.